The reason why so many moms go into breastfeeding with a lot of fear is because we live in a culture that is not very supportive of breastfeeding in general. It's getting so much better. But if you look back on our history, breastfeeding used to be this horrible, gross thing. Doctors would, in the early 1900s, tell women not to breastfeed their babies because formula companies were making so much money, and the doctors would make money from giving formula to the moms because the formula companies would pay the doctors. And it really, in the whole country, became a widespread, really big issue, and breastfeeding rates were really low. And now going forward, things started to improve, but oftentimes what happens is, especially in hospital settings, if there's not a lot of breastfeeding support, some hospitals are great and some are not so great with that. The mom is trying to figure it all out on her own and not getting the support that she needs or the education that she needs. And there are also some specific practices that can happen right after the baby is born that's really antithetical to what actually supports breastfeeding, like separation of baby routinely and aggressive rubbing of baby, trying to get baby to latch to the boob forcefully immediately. Practices that aren't evidence-based and really aren't supportive. And so I like to teach that there are it's called the rule of threes. But there are 3 windows for supply and for latching, kind of going well. And the first is the first 3 hours, and then the next 3 days, and then the next 3 weeks. So when it comes to supply specifically and latching, in the very beginning, in the first 3 hours, this is a window that can set the breastfeeding journey up to be really positive if we do some specific things in this window. And never ever does this mean that if things don't go well, if the baby has to go to NICU or there's some kind of separation, that breastfeeding is ruined. That's not true at all. But it is, I think, important to be mindful that right now we're in this really important window that can set up breastfeeding to be successful in the future. In the first 3 hours, there's this really special window. And what we can do to help support baby in latching on their own and for things to start out well is to do immediate skin to skin. Once baby is skin to skin with you, what you could do is something called baby initiated feeding. You're lying back, you put the baby on your belly or on your chest, and you just leave them alone and let them find the breast on their own. So sometimes after babies are born, depending on provider and depending on the hospital, the baby will be immediately rubbed with blankets. And the reason why providers do this is because it's the first step of NRP. So if a baby comes out and they're a little floppy, they don't have good tone, they don't have good color, they would want to start trying to stimulate the baby. If the baby comes out and they're they usually do this with their hands, they're what's going on? So they have tone. Their arms and legs won't be pink, but their chest and belly and their face is pink and they cry right away. That baby's transitioning well and is well oxygenated. There's no reason to aggressively rub that baby. That baby doesn't need neonatal resuscitation. Aggressively rubbing babies, where a baby's on you and there are several different people rubbing baby with blankets, can feel overwhelming for both of you. And it's not an evidence-based approach. So I just want you to know that. I don't think that necessarily could interrupt breastfeeding, but I think it can be kind of stressful for both of you. And any stress that we can reduce or avoid completely will be supportive for all the normal physiologic processes that need to happen for you, toning your uterus, releasing the placenta, controlling bleeding by releasing oxytocin. Stress hormones block oxytocin and can negatively impact your recovery. And stress can also impact supply. Just avoiding anything that feels stressful or unwelcome for you, knowing you have the right to do that, is important. If baby needs resuscitation, unfortunately, in many hospitals, they don't have the equipment to remain with a delayed cord clamping, to keep the cord intact while doing resuscitation. They would want to bring baby to a flat surface so that they can access the airway easier. Earlier stages of resuscitation typically can happen on your chest, which is ideal. We could put the baby on your chest, rub them, stimulate them, and then do there's called an ambu bag they could put on their face and give them some breaths, and sometimes that is all that's needed. In that case, it would be ideal if baby can remain attached to the cord and be getting oxygen and blood from the cord and can also be skin to skin with you. Some providers are quick or faster to separate baby and others are not. So if you have concern about that, I think it would be good to talk about. If that feels like something that's really important for you, you can say on your birth plan, I request in the earlier stages of resuscitation, if needed, that that's done skin to skin. And you can have a conversation and see how they respond and kind of talk to them about that so there's some clarity. Because it is true that some providers at the tiniest little sign that baby needs a little something will separate, which is often unnecessary. It is unnecessary sometimes, but not always. So you can request that if that feels important. So you can wait, even an hour and let baby initiate feeding. So this is a different approach from some models for breastfeeding where we put the baby on your chest and then give baby just really a few minutes, not really a lot of time. And then we're immediately having you hold your breast. Someone holds baby's head and they just shove. That's the word I hear when women describe this, they're shoved my baby on my breast. So we're just forcing the head to come to the breast. That really isn't necessary or supportive. And it can be kind of confusing for babies. When babies are first born, they don't need to eat immediately because they have a full belly from all the nutrients that they got, especially if they got delayed cord clamping. There are certain circumstances, like if the baby has low blood sugar because you had low blood sugar in labor, perhaps. If you have gestational diabetes that isn't maybe controlled very well, baby could have a blood sugar crash after they're born. If the baby is sick or has an infection, anything like that would mean that baby needs sustenance sooner and also might be too sleepy to initiate feeding on their own. But there are signs that baby wouldn't be doing well, and in that case, providers would respond. And if you ever feel concerned about your baby looking kind of lethargic or not being that interested, you can always request someone to check in and support too. Typically, if something like that is happening, like a low blood sugar thing, you could hand express colostrum and you could put it on a spoon and spoon feed baby, or hand express or even pump colostrum into a syringe and give it to baby that way. And sometimes that gives baby the little energy boost they need to have the energy to be able to latch and move forward with that. So that's rare, but those are some options if something like that were to happen. And so this alternative model to just shoving baby on the boob is that we give them time and we just let them find it on their own. It's really cool. Your baby will really be able to army crawl if they're doing well, bob around, until they kind of find it. And some signs that they're really looking is going like that, with an open mouth, kind of bobbing around, maybe sucking on their hands, smacking their lips, and they might even cry if they're getting frustrated that they can't find it. And typically if they start to cry, I would give them some support. The approach that I encourage people to take is to see if you want to allow your baby to initiate feeding on their own, or just hold your baby near your breast in a supportive way. You could tickle the baby's, I'll teach you how to latch, so you can do some early latching stuff, tickle the baby's mouth with your nipple and see if they open. And if they open, you can bring the baby to your breast and start feeding that way. But no one needs to just shove baby routinely. It's ideal for them to nurse in the first hour, but so they don't need to nurse immediately. The next windows are the next 3 days and the 3 weeks. And so the things that can be supportive, the practices that you can do to support in these windows, encouraging baby to be feeding frequently and often, and well, which will help to support your supply and teach your body how much milk to make for your baby. In addition to helping latching going well, so whatever you're doing is sustainable, is to be skin to skin often. So some parents, they have their baby and they go home and the baby wears clothes and they wear clothes and they're kind of up moving around kind of right away after birth. I highly recommend that you do an extended rest period as long as you can to support your healing in your pelvic floor and help control bleeding, so that you don't end up down the road experiencing adrenal fatigue or pelvic floor dysfunction or things that can be prevented with proper rest. And this is one of the most supportive things you can do to help you and your baby have a successful breastfeeding journey, is in these first few days and weeks to be in your bed, topless, with your baby on your chest, and just be skin to skin as much as possible, as much as feels good for you. Skin to skin time is so good for babies because in the really early weeks of their life, they can't regulate their temperature the same way that we can, and they regulate their temperature and vitals on our skin. And also being skin to skin with your baby encourages more on-demand feeding, meaning we feed when the baby cues, and we're more likely to notice a cue early before baby gets over hungry or over tired if they're wanting to use the boob to go to sleep, and which can then, if they're over hungry and overtired, make them fussy. It's harder to latch, things like that. So just staying in that environment is really ideal and super supportive. And the next thing that I would say is to make sure that you're latching well and you're getting the support that you need for the experience to be sustainable. So sometimes with breastfeeding, we might just be like, I know we're feeding the baby so often, so we're like, I just want to, like, you're crying, I need to feed you, so I'm just going to pop you on the boob before really getting comfortable or before really making sure that the latch is good. And so what can happen is the baby's like, sucking on the nipple in a way that is not very supportive for your nipple. It can be uncomfortable, and sometimes we just choose to deal with the pain rather than dealing with getting comfortable and correcting the latch. It's always better to get comfortable and correct the latch, because if we get kind of lazy about it and we allow feedings to happen that are uncomfortable, it's going to cause more discomfort in the future, and we can start to actually hurt our nipples that way. So if you're noticing any signs that latching isn't going really well, like you're experiencing a lot of pain, or you're noticing your nipple comes out shaped like a lipstick tube, which means it's being pinched on the roof of the baby's mouth, things like that. Baby's not gaining weight very well. Though all those things mean that we want to look at the latch and get support right away and making sure. So addressing things early on is really important. The nipple, basically, like when the nipple goes into the baby's mouth, we want the baby to not just like get the nipple, we want them to get as much of the areola as possible around the nipple, if that makes sense. If you were to eat a sandwich, you can notice next time you eat a sandwich how you do it. But typically, we don't go straight onto the sandwich. We kind of lift our chin up and kind of bite from the bottom to the top, if that makes sense. It's down and up. And babies do the same thing. So when we're latching, to come down a little bit from the bottom, and they typically will come down on the bottom and then they'll come to the top like this. And they'll take as much of the top part of the areola in their mouth as possible. And that would be really ideal, because if baby is just getting the nipple into their mouth, they're pinching your nipple on the hard roof of their mouth. And that's what can make your nipple look like a lipstick tube, because it's being compressed, and that's what causes pain. But if a baby comes down a little bit lower and they take on the areola around the bottom and the top, then they're nursing like this. And so they're compressing on the areola, which is actually what's bringing the milk out. Because the nipple isn't like a straw that they suck to pull the milk out. They have to work it out by putting their mouth around this whole area. So the first thing that I would do is tickle their mouth with your nipple. So that would look like I would get in a comfortable position, and I would bring the baby up to you, and I would do this. Tickle, tickle, tickle. And when we do this, we encourage the baby to open their mouth. And we want them to open their mouth as wide as possible. So this might take a few tries. You might tickle, and they'd be open, and then they're closed. And you're okay, tickle again. And we kind of just do it until you see them give you a really big open mouth. And then once their mouth is nice and open, I take the baby and I bring them to the breast. I don't bring my breast to the baby, because then I would be like that. And we don't want that, because that doesn't feel very comfortable. We want to be nice and comfortable supporting our breast with our hand and tickle, tickle, tickle. And then baby opens their mouth and we go whoop, tickle their mouth, and then baby to breast. Let's talk about how to identify a good latch from one that maybe isn't doing so well. Their cheeks are rounded, not sucked in. So when they're sucking, they're not like that with this little divot happening, but you can see their cheeks are rounded. That's a sign that the latch is good. Another sign is that you can hear them swallow. So you're hearing swallowing sounds when they're drinking. They stay on. Some babies will nurse, nurse, and then pop off, reposition, nurse, nurse, pop off. So that means that there isn't a latch that's like, sustainable. The pain, if you're experiencing pain, which is common in the first few days or even a week, it ends in the first like 5 seconds or so. Yeah, so when you're experiencing like normal nipple tenderness in the first week, because we're getting used to our nipples being sucked on often by a baby, typically you'll do the latch and you might feel some tenderness or some pain as soon as the baby latches. And usually just by taking one deep breath in and out, the pain is gone. If the pain continues, it means the latch is not a good latch. And after about a week, you shouldn't be experiencing pain anymore. And the more you're latching well, the less pain you'll have, because pain is typically a cause of a latching issue. So